And we are live.
All right, everyone, welcome back from lunch hour, after 1 p.m. on March 11th. We are having a conversation about our OPR bill H588, and we are taking a look at a proposal of amendment. And that is being introduced by Representative Black. She's not here. So what I think I would like to do first is just bring up counsel to discuss the proposal with us through his lens, and then we'll get to our guests.
Thank you very much for having me today, committee members. For the record, my name is Tim Devlin, Legislative Counsel. You have draft 1.3 of a individual amendment, although it's from numerous representatives, as you can see. This will add a single section to the bill having to do with pharmacists to be section 14A, which will amend 26 BSA 2023. I should initially note that this same section is being amended in another bill, but doesn't conflict. It's a different subdivision. And so this will retitle 26 VSA 2023 as
Counsel, one moment, I have a hand.
Oh, sure.
You said 1.3, but I only have 1.2.
Did you refresh your page?
Yes.
I haven't.
I may not have provided the most up-to-date version
Okay.
to the committee system.
Right.
Apologies for that. The difference is the list of sponsors and then one reference to the federal code here on, let's see, line 20, page 2. That was it was the wrong federal. It was referring to statute and not regulation, I think, or yeah.
Okay.
So that was corrected. That's the only difference between 1.2 and 1.3. So I think we can still work off 1.2 adequately. So the statute will be retitled Clinical Pharmacy, Prescribing and Testing. And we'll see our first added language here under A3. So reading them together, it will state, in accordance with applicable rules adopted by the board, a pharmacist may engage in the practice of clinical pharmacy, including prescribing as set forth in subsection B of this section, which we'll get to, provided that the pharmacist shall not, 3, initiate antibiotic therapy pursuant to a collaborative practice agreement or state protocol. And moving on to aforementioned B. Pharmacists may prescribe in the following contexts. 2, state protocol. A, pharmacists may prescribe, order, or administer in the manner consistent with the valid state protocols that are approved by the Commissioner of Health after consultation with the Director of Professional Regulation and the board, and the ability for the public comment. And then we skip some subdivisions here. X, or 2, Roman X10, emergency prescribing of albuterol or glucagon while contemporaneously contacting emergency services. That's not changing, but what is following, we're striking what was 11 and 12 here and keeping 13, but renumbering it and adding, let's see, tests waived under 42 CFR, go to federal regulation, section 493.15 for COVID-19, influenza, streptococcal pharyngitis, maybe garbling that, sorry, and subsequent drug treatment. And then we omit the rest of the subsections and sections here. So the meat of it is removing tests for COVID for individual, et cetera, under 11, 12, similarly for tests for SARS-CoV, and then replacing with tests waived under that federal provision, COVID-19, influenza, et cetera, et cetera.
All right, any questions for counsel on that? Okay. Thank you, sir. I think next I would like to shift over to the Deputy Secretary of State and OPR. Great.
Afternoon. If Jen and I can testify together as we like to do, even though we are not together, that would be great.
You are in my head. I was actually just gonna tee up the digital to like live in 3D, like duet, because hey, why not utilize all the tools?
Shoulder.
Absolutely. For the record, my name is Lauren Hibbert. I'm the Deputy Secretary of State, and I'm beaming into you from Washington, D.C. So thank you for that flexibility. I'm going to let Jen do the bulk of the testimony about the amendment. I just want to say a deep appreciation to the chair and this committee for taking up this amendment. This was something that came to light rather quickly, and it makes sense. It's a relatively easy amendment in many ways. It makes sense to do before it passes out of the House floor, and I just really appreciate the opportunity to do this. So thank you. And I wanted to let the committee know that I know of a potential amendment that is coming on this bill on the Senate side. And I just want to, in full transparency, I like to give heads up on these things. We are working with the Board of Medical Practice on an amendment around the FBI background checks for the Interstate Medical Licensing Compact. And this is a great avenue for that, even though they're not part of OPR. They're a strong partner with OPR, and their criminal background check issue impacts our licensees as well. So I do think it's relevant. We're going to argue for that on the Senate side, and I know that. And so I wanted to give you guys a heads up on that as well, since this has been your bill. So with that, unless you have any questions about that potential amendment or anything else related to my gratitude, I'll just say it again. Thank you, and I'll turn it over to Jen.
No, thank you. And thank you for the awareness on that. And I'm sure we'll have questions once that starts to evolve, but let's stay near term right now unless somebody has a question on that one.
Great.
All right, to you.
Thank you so much. Jennifer Colon, Director of the Office of Professional Regulation. Good to see y'all. So just coming today to fully support the amendment to H588. Thank you so much for this amendment. It allows test to treat in pharmacies for limited conditions such as namely COVID-19, influenza, and strep as a way to increase access to care. So this came about as part of the Rural Health Transformation Program grant, which it's our understanding that grant funds were recently approved for the fiscal year, and Test to Treat was one of the initiatives that was included in that grant process as a way to increase access to treatment for these limited conditions. As you know, it's quick to go into your local pharmacy, and if you have or you think you may have strep, COVID-19, or flu, to be able to test and get treatment at that point of care is maybe is a way to streamline care, and in a lot of cases much easier than making an appointment with your primary care provider. So for these conditions where timing in treatment is critical, it's good to be able to have an easier access to this treatment. So the proposed language allows testing and treatment of COVID-19, influenza, and strep by pharmacists in the practice of clinical pharmacy via a state protocol that would be approved by the Commissioner of Health, and as the result of collaboration between the Commissioner of Health, OPR, and the public. It's something that would go out for public comment as well. These are, again, limited conditions with fairly straightforward treatment. And from OPR's public protection lens, which that is our mandate, public protection, pharmacists have the training and education to be able to safely and effectively provide this service, particularly under the guidance of and in accordance with a protocol developed by the Department of Health, which would have additional procedures for pharmacists to follow when doing the testing and treating. Also, just important to note that quite a few other states do allow test to treat via state protocols, as well as collaborative practice agreements. So this is something that's done in other states, and we fully support this effort.
Any questions for Jen?
Thank you.
Madam Chair,
Oh,
welcome.
Thank you. I admonish my committee every single year about the importance of being on time because everyone's time is valuable. And I apologize profusely. I
kept the train moving.
got single-minded in thinking about AI and mental health. So,
Stress ones.
so I understand that you've already had a walkthrough of the amendment from Legislative Council. I will just say that we have met with Agency of Human Services even before the session began around the Rural Health Transformation Grant that I know that all of you know about, because I think you guys are working on an EMS bill also that might pertain to that. And one of the grant proposals in the application, which was approved, was this test to treat. And we always intended to do this. It was very small statutory changes that needed to be made to the licensure around pharmacists and enabling them to do this. So this legislation is necessary in order for us to move forward with the RHT money that has been allocated to this. So that's why this proposal is before you. We took testimony from Department of Health, not Agency of Human Services, but Office of Professional Regulation, as well as the Vermont Medical Society. This is treating after testing is within the scope of practice for a pharmacist. So we are not expanding their licensure at all for something that they are unqualified for. They are trained, they are licensed to do this. This is an access issue. Imagine, we talk about access a lot. We talk about primary care a lot in our committee. And, just the ability to be able to get a visit with your primary care physician, oftentimes you can't get in for a couple days, which if you have the flu, let's say, you can go to your pharmacy. They can test you because there are instant tests for influenza now. And this is now allowing that pharmacist to prescribe you with Tamiflu, which needs to be given at the beginning of your flu rather than later. And it can shorten the course and it can make much less complications from the flu. Same thing with COVID. Why am I blanking on the medication?
Paxlovid?
Paxlovid, thank you.
I got you.
Okay, Paxlovid and Streptococcus antibiotics. These are standard treatments, and the sooner that they are given, the better outcomes for the patient. And oftentimes, if you can't get into your primary care physician, you're making people miserable. So this is safe, this is effective, and that's why you have this amendment before you.
Thank you.
Speaking of access currently, I will just say, if you can't get into your primary care, you are then going maybe to an urgent care if your community even has an urgent care, which we don't have a lot of around the state. Or oftentimes you'll just end up going to the emergency department. Because when you're really sick, you want help and you want help now. So it's really saves on costs.
Yeah, time.
Time, costs, effective treatments in a timely manner.
Sounds to me. Any questions? You have Hango.
Just a quick question, maybe I missed this somewhere. Is the pharmacist the one who does the actual testing as well? Like you can't bring in a home test and say, here, I have strep, could I have treatment for it?
Yeah, no, they would test there. And there is provision, if you look at existing law, it's around CLIA. You have to have what does CLIA stand for? certificate of
I can't help you on that one.
clinical laboratory
Amendments.
amendments. Yes. You have to have a CLIA waiver, and that is what allows facilities to provide testing. So no, testing would be done there by the pharmacist, and then treatment would be rendered. And once somebody has been treated, that information would then be communicated to their primary care physician so that we're ensuring continuity of care.
Does it say that in the bill somewhere or or is that part of the CLIA that the?
It's actually part of the rulemaking that OPR has, but it would better OPR to speak to that than.
Oh, excuse me.
Would
It
you-
would be part of the state protocol.
Okay,
So that's what's developed with the Commissioner of Health. The state protocol has all those details in it about process and records and that sort of thing.
thank you. I'm just questioning that because in the past, as this committee knows, I've had a disconnect between the pharmacy and the primary care. So I want to make sure that was in there.
That will be part of it.
Thank you.
Prep this one.
From just gonna use our area, we only have one pharmacy in like a 50-mile circle. It's very, very busy. And so now some of the pharmacist techs are authorized to give shots. So would they fall under that CLIA where they would be able to give the testing as well, or is it just the pharmacist?
It's just the pharmacist that can prescribe.
But they could do the test and then give the pharmacist results? I'm just concerned that we have
Yeah,
one
that's-
pharmacy that's so busy.
That's a valid question for a different,
It's gonna be.
valid question, different witness.
Yeah.
Yeah.
And I will say, because that is a concern, this is voluntary for pharmacies. So if pharmacies don't feel as though they have the time or inclination to be doing this, they don't have to do it.
Just see our poor pharmacists, just like, I mean, you go then there's just piles of pill boxes ready for her to go through and verify and. This can't, I don't want to see our pharmacists become an emergency room for strep and COVID-19 or whatever, so I just see her throwing her hands up in the air. Yeah, it's,
She might choose not to participate.
yeah, it would be nice if her assistants could at least test and then she would prescribe to help the flow. That was my question. Would they be able to assist?
Well,
I think that would be a better.
that is our next witness is the Commissioner of Health. Yes.
Okay.
But do we have anything else from Madam Chair? Seeing no hands.
Thank you. Back to AI. Again, I apologize.
Hey.
Thank
You
you
were.
for the, thank you for the heads up, ranking member.
You're quite welcome anytime, my friend.
All right, thank you. And next, we're gonna shift over to Dr. Hildebrand, Commissioner, Department of Health. How are you doing, sir?
I'm well. How are you?
Doing just fine, thank you.
Again, for the record, Rick Hildebrand, Commissioner for the Department of Health. This is my first time before you all. Thank you all for having me here. And I'm going to be a little bit of an echo of what you've heard so far. Access to timely healthcare is an important public health indicator. And that's something we struggle with in Vermont. We've got a number of rural communities. We've got a limited and aging primary care workforce. Stephanie, I know will tell you, listen, if we had as many primary care physicians as we wanted across this entire state, we wouldn't probably be having this conversation, but that's not the real life scenario. We have huge access issues that has been really challenging to provide care to people. I can tell you that I see this all the time. I work in a hospital, care for folks on the inpatient unit, and when I discharge someone, you'd think I would be able to get people the next day, and I sometimes struggle to get someone as a follow-up appointment for a week or more. There's a real challenge in getting timely appointments for healthcare. When it comes to some infectious diseases, it's really, really important to get timely access. So in this amendment, we're talking about 3 different things. 2 of them are very similar, influenza and COVID, where if we institute treatment that can shorten the duration of illness, the symptoms that people are feeling, and let people get back to work faster and feel better faster and avoid some of the major negative outcomes related to these illnesses. As an example, with influenza, if you're not diagnosed for 72 hours, you're not eligible. It's no longer indicated to give Tamiflu. So, I mean, it's a really tight time frame from when symptoms start. And oftentimes people don't call the moment their symptoms start. So, timely access is really important. With strep, I mean, if we don't have timely treatment for strep, we can end up with valvular heart disease. It can really be quite serious. So, we were very intentional about windowing this to diagnoses and diseases that are amenable to this process, to this test history process. And we'll be working very closely with our primary care partners and the Vermont Medical Society to make sure that the protocols that we develop, and in conjunction with, of course, OPR and the pharmacy board, is what we all want. Okay, it's got tight guardrails. It ensures that we have great inclusion and exclusion criteria. It ensures that we have follow up as part of it. Everything that we would want, collectively as a healthcare system, we want to have in our protocol, and that's where it's going to be specified. We are in support of this because we know that this can make a big difference in the lives of many folks. I think, as you've heard testimony already, this isn't coming from RHTP, right? So we would like to use the funds from RHTP to get these programs up and running, and that will require some capital investment, which we can get from RHTP. But the other piece is this can give some revenue to pharmacies. I mean, these are revenue generating services, and our pharmacies are strapped. I don't think that every pharmacy in the state will avail themselves to this, but I think for some, they can make a good case to actually increase their staffing with programs of this nature. And I do hope that is the case, because we see that where communities have one pharmacy, and they're really, really struggling to keep up. They may not be able to operationalize this, and we fully understand that, but this is an option, and may be helpful to not only to pharmacies, but certainly to ERs, to primary care offices, to other folks for these 3 diagnoses. And I welcome any questions.
Thank you, Commissioner. Rapkoff?
Oh, I was pointing to Sandy about her question to try to get in. Would the assistants at the pharmacies be able to do the testing and then provide the results to the pharmacist? Is that something they could be trained for, or is that built in the rules?
So I don't believe it's built in the rules. It's something I would definitely want to investigate fully and get back to you on, because you're right. We want to make sure that we are operating at the top of our license is the term we use in healthcare, so that if a pharmacy's tech is within their scope of practice to do a thing, we want them to do that thing and not have it go to the pharmacist or to a higher level provider. I don't believe that we have the statutory allowment to do that, but that again is something I will investigate and get back to you, because we certainly would want to make this make sense for everyone involved.
Okay, thank you. Because that would help the pharmacists too and help the community if that was something that was possible to do.
Agreed.
And I'm just gonna let the gallery oh, yes, please.
No, I was.
Oh, never mind. I will let the gallery do its thing for a moment. Anything else for the commissioner while the gallery is doing its thing?
Nope.
All right, well, so we are on standby.
Thank you so much.
Yeah, of
Thank you.
course.
Okay, sorry to steal your thunder.
No, no,
Trying to
that's
get your
fine.
attention to ask
Yeah,
that
no, that's
question.
fine.
It's a good questions.
I know that we have one pharmacy in my area, and the pharmacist is really busy. So if,
Takes 2 days to get a prescription filled. That's how busy they are.
so if there's people working for them to do the testing, help speed up the process, that would relieve some of the pressure. And I don't know what the training involved in that. It's not my.
No, I was surprised when I went to get my COVID shot that the technician could do the job.
Please.
Yes. Jennifer Cullen,
Please.
Office of
Yes.
Professional Regulations. We were just taking a look at our current statutes, and right now pharmacy technicians are authorized by statute to administer COVID-19 tests only. So in other words, if pharmacy technicians, if we wanted them to have the authority to be able to administer tests for strep and flu, that would need to be a statutory amendment. And so that's the current state of
A
things.
much bigger conversation than the conversation we're having right now. Yeah. Yes, right.
But is it really a much bigger conversation because COVID-19 and flu are very similar? I'm not familiar with the test for strep, that if that's any more complicated than a flu or COVID-19 test. Because it almost makes sense to talk about it here.
Yep.
Yeah.
Agreed. It sounds like the flu and the COVID-19 tests are the same.
They all can are tests, so
Okay.
it's probably the same
And-
exact procedure.
And this is Carrie Phillips, the
Yes.
Executive Officer of the Board of Pharmacy. So she's with us today. So Carrie, did you have something you needed to add?
Well, they are frequently the same exact test. That's a nasal swab, just like the COVID test. And there are combination tests that can test for more than one thing. The test for strep probably is different because it would be a pharyngeal, a throat test, not a nasopharyngeal test, probably not terribly familiar. But it's certainly, I believe it would be certainly within their skill set to add on to if that was something that the General Assembly wished to do. Providing the stakeholders are amenable. And thankfully Stephanie just showed this to me, so it's certainly something that could be a discussion.
Okay. Now we have a better understanding of what exists
Yes,
and how it intersects.
yes.
Yeah, okay. Yes, Representative Mango.
This may be a question for our next witness, who I think is the pharmacist, but once a pharmacy tech administers the COVID-19 test, I assume they bring that test result to the pharmacist, and then the pharmacist administers the treatment or dispenses the treatment. So just thinking along these lines, if flu were also treated the same way, a flu test, and if they were a combination test, would the same protocol happen, same procedure? The pharmacy tech would bring it to the pharmacist, and the pharmacist would decide on the treatment and dispense it.
And were you looking to ask that question of the next witness?
If she's ready to answer
Yes,
it.
please. Yeah, join us. Introduce yourself for the record and
Thank you.
the table is yours.
Hi, happy to. I'm Dr. Lauren Bodie. I'm a pharmacist and the legislative liaison for the Vermont Pharmacists Association. My thanks to everyone for taking this up. I'll just say in brief that that really there's not much for me to say because you've already heard all of the reasons why this just makes a lot of sense for us to do. Pharmacists and community pharmacists are a part of the primary care infrastructure of our state. And so it does make sense to use our pharmacists as a way of expanding access. So we're accessible, we're knowledgeable, we're trusted and trustworthy. So yes, I think this all makes sense to do. To the specific point of pharmacy technicians, I would highly advocate for creating a way for the actual administering of the test to be delegated under the supervision of a pharmacist in the same way that it is for COVID-19, and basically expanding it across the disease states that we're talking about today, because it would work essentially exactly as you're saying. So, the pharmacy technician plays a valuable role in operationalizing any workflow, which in this case, could be facilitating intake and maybe administering the test, but then the clinical activity of evaluating the test result and determining appropriate treatment, if any, or the decision to refer, or whatever the case may be, that will rely on the clinical decision-making of that highly trained pharmacist. Are there any other direct questions I can I can answer.
I do have a hand here, yes.
Yes.
Representative Coffin.
This is actually for Dr. Hildebrandt. For a strep test, is it just from what I experienced with my own children? Is it just normally a throat swab, just a swab for mucus?
Yeah, so it's a nasopharyngeal or in the nose is for COVID and flu. Oftentimes the same swab used for both. A pharyngeal swab or throat swab is typically used for strep. So swab in the throat in the peritonsillar region around your tonsils is typically where the sample is collected for a strep test.
And I don't know if you can answer this or not, but in your opinion, would it be just as safe for a assistant at a pharmacy to be able to administer this test if it's a simple swab?
I think it's something that we should make sure they're trained to do, but it is not incredibly dissimilar from swabbing a nose. It's just a different region of the nasopharynx that we're swabbing. So I do think if someone can be trained to swab a nose, they could be trained to swab a throat, but again, would want to make sure that they were adequately trained to do so.
Yeah. Oh, definitely. The training needs to be there. I'm just trying to figure out a way to get this all wrapped up.
Fair enough.
Thank you.
And I just saw a deputy secretary show up. Are you jumping on the screen?
Yes.
The table is yours, Madam Deputy
Lauren
Secretary.
Hibbert for the record again. If I can recommend, what we would like to do is consult and talk about this more with our Department of Health colleagues and make this modification. It's a very good catch by this committee, the pharmacy technician component. This is why the process works so well, is we all have good ideas and we work collaboratively. So thank you for that. But we would like to talk through the appropriateness of particularly the strep test for pharmacy technicians, and likely, depending on the outcome of that, we'll ask to modify the pharmacy tech language on the Senate side and would ask to give you a heads up. There will be other amendments to the bill, I'm confident. So we're going to be coming back to you anyway. But this is something that rather than try and solve it in this hour, in this committee, in this week, if we could just have a little time to talk about it, I promise you that we will, and we'll come back to you on the issue.
Okay.
Reasonable.
Thank you
Thank
very
you.
much.
Okay, with that understanding,
Mhm.
we're just gonna refocus to the direct words on the page right now for consideration of this amendment for inclusion of the bill that is getting voted out of appropriations any minute now. So any other questions for our guest from the Pharmacy Association?
If not, may I echo one other comment of Dr. Hildebrandt's?
Oh, absolutely.
Thank you. I appreciate it. The thing that I really appreciate, and I not for action, in this exact hour today, but in recognition that the full promise of implementation for this is going to rely on there being a sustainable mechanism for reimbursement for pharmacies to implement these services. I just, am looking forward to, participating in ongoing conversations about how we can support creating those pathways. Because I do absolutely agree with Dr. Hildebrandt that there is a potential there for this to be a part of helping our community pharmacies remain financially sustainable and therefore present in our communities. But there actually are likely some regulatory changes that would need to be implemented to actually facilitate that. So just hope that we can continue to have those conversations, and I really appreciate this.
Thank you so much for your time. And if you want to stick around just in case something else pops up that's relevant to you, that'd be amazing. So let's see. Leaves us with Stephanie Winters. How are you?
I'm just peachy. How are you?
I'm well. Haven't seen you around here in a while.
No, I haven't been in this committee room. That shows how long it's been since I've been here.
Room 10, right? Yeah.
Yes. Yes.
Welcome to our new abode.
Thank you. I like it over here.
It's all right.
Yeah.
Okay.
Yeah.
Yeah.
Stephanie Winters, I am the Deputy Director of the Vermont Medical Society. And for those that don't know or who are new, the Vermont Medical Society is a physician and physician assistant membership organization representing over 2/3 of the licensed physicians in the state. So thank you for allowing me or inviting me to testify today. And Dr. Hildebrandt stole my thunder on the primary care piece, but I will reiterate that, as we continue to build our healthcare system, we have problems in one area and then we push it to a different area and push it to a different area because they become overwhelmed. And so we threaten overwhelming lots of different systems without really fixing the original problem. So hopefully if you have bills come across you in the House, hopefully after crossover, that will help build primary care, I would ask that you support them. So that's all I will say to that. But on this bill, I want to begin by saying that we explicitly that pharmacists are essential members of the healthcare team, and that we have worked within the Vermont state protocol system that really does work for pharmacist prescribing. And we appreciate that this amendment is tight. It is very medication and condition specific and protocol driven and not open-ended. We would be concerned with broad unrestricted test to treat authority. And we do appreciate and support that the amendment language is condition or medication specific. Just a little bit about the protocol based approach. We've had a strong history of collaboration between prescribers, pharmacists, and regulators. And in 2020, in fact, this body passed a landmark example of expanding pharmacist prescribing authority safely and deliberately. And that is through these jointly approved protocols by OPR and the Department of Health. And so this model, which has the Board of Pharmacy come up with protocols that then are opened up to the public. I have been able to attend all of those and we provide comment. We've had really great open discussion and been able to discuss issues and really come to what is best and safest for the patient. So I have appreciated that. I think I will just end because everything's already been said, but that we support safe collaborative models of pharmacy engagement, those that complement, not replace the patient-centered medical home or primary care, and that we support that this language is condition or medication specific and protocol driven. And we look forward to being part of the protocol process, which we hope will address information sharing, coordination with primary care, and notification after prescribing to the primary care so that we make sure the medical records are up to date and everybody knows what the patient, what is happening with the patient. And then, as you have talked about, include training, oversight, and outcomes to protect both the patients and the pharmacists. So with that, I will conclude and say thank you.
Any questions for EMS? All right.
All right. Thank you.
So this was good timing. I just was sent a text by Chair of Appropriations that H 588 was voted out 11-0. So that is moving. How does everyone feel with the moving parts and the understanding of this? Does anyone have any open questions?
No, are we just waiting to hear back from Secretary of State's office now about the pharmacy tech? Or we just?
No, they're gonna do that over there.
They're gonna do this.
Yeah, they want us to focus here.
Okay.
And then that conversation will happen
Great.
over there. So we are just really focusing on this.
On this part. Okay.
Correct.
Just wanted to clarify. Sorry about that.
No, not at all. Totally. That was a lot of moving parts. Valid question. Rep. Pismo.
So the conversation that the pharmacist brought up regarding billing, that would also go over there?
Yes, I would presume so. Yes, Rep. Engel.
My understanding is that's part of this rural health
It's a
transformation,
bigger-
Okay,
from the federal government to the tune of like $195 million. And that's going to be decided by somebody other than us. Because they have really specific guidelines for that money.
Correct. And this here would be funded with those dollars. Any cost associated.
right.
I like it.
I mean, they already billed for for shots and stuff, so why couldn't they bill for the time of testing as well? I like it. Just I don't see the pharmacist overload.
Right, that's why I like that, if the conversation continues in the Senate about making sure that the assistants are properly trained and can do these other tests and then the pharmacist can prescribe,
Yeah.
and then all in safety. I hope the Senate continues on that mode.
Madam Deputy.
I just wanted to, yes, for the record, Lauren Hibbert again. I am in no means an expert in medical billing, healthcare billing. But it is a very complicated system. Changes to who's reimbursed and by whom are regulated by DVA and Medicaid, Medicare, and the private insurance industry, and regulatory rules. There, and it sometimes can be directed by statute. So it's a governed by a lot of different things. And I see that Lauren Bodie, who I always like to testify with, just chimed in too. But it's a complicated network, and it's not always an easy to change. But what I think this group is committed to is enabling payment to pharmacists and making sure that it is cost effective for pharmacies to be providing these services. I think that's in the mutual goals of everybody who you vote from today.
Thank you.
Anything to add?
Lauren Bodie with BPA. Yes, not to minimize the complexity, but these are not insurmountable challenges. These are challenges that many other states, I think now 37, have gone through and have kind of figured out, essentially, for lack of like a more like refined set of terms, to figure out how to open up like pathways for pharmacists to be able to do billing. And so by no means, so yes, complex, not impossible. There are some fairly straightforward things that we could start doing from a regulatory side, in particular in DVA, to kind of like start this ball rolling. And I also want to note that we actually have precedent. Back in 2021, there was a bill that required commercial insurers operating in the state to provide pathways for pharmacist coverage. So again, complex, but not totally unknown, and definitely not without precedent. And so my purpose in bringing it up is just to offer support and ask for help in terms of starting to unravel just elements of the complexity.
All right. So, any other questions or comments? All right, so this would be a floor amendment that would be presented by Representative Black. So our position right now will be a straw poll, so we don't have a session bill. Pretty clear on that one? So, all right, no other comment, input, or questions? Favorable thumbs for Representative Black's amendment. All right, and that is a 902 on the thumbs. Thank you. All right. I appreciate the time on that. It was an important amendment that came a little late, but hey, that's what we do here, right? Yeah. Thank you so much, and please get back to conferencing, I guess. We're
Probably
here if you need
recognize
it.
the hotel drapery. Thank you. I will do so.
Absolutely, I know, yeah, yep.
Hotel lamp gave it away.
I think I had that room once. All right.
Wasn't she here this morning? Was she in the building?
No, that was yesterday. Yeah. All right, folks, thank you very much, everyone. So we will be back in 12 minutes for council to just keep mining through the emergency management bill. So we got a 10-minute break until 2 o'clock with